सो ग्रेट। 4:30 बज चुके हैं शाम के। बहुत बहुत स्वागत है डीटीओस। वेलकम यू ऑल फ्रॉम ऑल अक्रॉस द कंट्री। देयर इज सो मच टू डू। There is so much to do today because our PDSAs are going on. The counselors are so very active with you. We finished about 14 PDSA presentations last week. We have as many lined up today. We have a wonderful guest speaker with us today. Dr. Jain is going to share a lot of his things that he has in mind. So I will not waste a single moment by speaking, even in trying to welcome each one of you. So Dr. Jain, may I request you to share your slides, present this thing, and please tell us what do you have in mind, whom have you brought today, and what we can look forward to in the session. And what I suggest is we will hear you a bit, then we will have some PDSA presentations, then we will hear you a bit more and have the DTOs involved in those discussions, and then continue with the PDSA presentations. So it will keep it interesting.
Absolutely. Thank you, Commodore Raman, and welcome everyone. So we are well into doing our PDSAs and looking at how to improve notification. But before we talk more on that, just what we really need to also think about is what does it take to increase notification? कि notification के पीछे क्या-क्या चीजें करनी पड़ती है जिससे notification increase होता है. और एक बहुत बड़ी चीज जो है वो है it is presumptive examination rate. For this, we will have Sandeep Mishra, who is going to join us. And I want to introduce Dr. Sandeep Mishra. He is a program manager at Wadvani AI, a brilliant person who has worked with me for nearly 5 to 7 years. Sandeep, अपन कितने साल से measures पे काम कर रहे हैं? He's also a public health officer who's worked in the field of TB for 18 years and also been with WHO and number of places as well. Welcome so much, Dr. Sandeep Mishra.
Thank you, sir. Actually, I have been working with you since 2009 when you initiated this city for the district of Indore in Madhya Pradesh.
Exactly.
Since 2009, we are associated and
wow.
The cause of elimination of TB.
Excellent. Okay, so I'm going to set the stage up for a conversation. Then we will have some PDSAs. Then Dr. Mishra is going to go into depth on the topic that we've talked about. And then we'll have an interactive conversation as well. So aapke questions, your questions, keep them ready. Chat mein dal dijiye ya you can raise your hand. Really interactive session we will do. So I come to this conversation of presumptive examination by a study which really excited me. Purani study hai, it's old, but it makes us think about how do we increase notification. So just this was done in one of our states in Chhattisgarh, where what they did was they enhanced TB case finding, meaning notification, through advocacy and sensitizations. Remember, all of the conversation we have had in PDSA, we have talked about if we increase advocacy, if we increase sensitization, will it make a difference? So they did it in a very niche population, the prisons. And this is what they found. Look at this. In 2013, old study, I agree, but the point is one major point. What does action, directed action, how does it change things? Their presumptive examination when they were not doing any intervention was 5,983. Prison population hadn't changed. Symptomatic presentation hadn't changed dramatically. When they did some action, it went up by nearly 30% to 8,322. Look at this. If you examine more, what happens to your positive rates? 316 to 412. What we see is that in any high risk, especially high risk population, you can increase your notification rate by increasing your presumptive examination rate. So how to increase notification? What they found was sensitization meetings they did to improve awareness. Prisoners about TB symptom services were coupled with improved access. तो उन्होंने क्या करा? Notify sensitization kara, and by that 39% per 100,000 and increased notification rate by 38% in just 1 year. So the bottom line, presumptive sputum examination is an important indicator to increase notification. It can be अपन और बातें करेंगे, ये process measure भी हो सकता है और outcome measure भी हो सकता है. And if you increase your presumptive sputum examination, you will definitely increase your notification and find the missing cases. सबसे बड़ी problem ये हो रही है, after we have seen the pandemic's effect, we are missing lots of cases. This will go up until there are no cases remaining. So if you have plateaued and there are no cases remaining in your district, then your even after you have high presumptive examination, your notification will have plateaued. So Commodore Raman, with that, I will pause and let us hear with our PDSAs from our DTOs, and then we'll have Dr. Sandeep Mishra engage us in a conversation about how to increase notification through presumptive sputum examination and its value.
Manoj, can I add one thing here? Simple.
Absolutely, please.
Yeah. The TB is a very interesting disease. It speaks by coughing. So the cough is there. In fact, it has been noticed that these patients knock the doors of various doctors. In fact, before they are diagnosed, they are knocking 1 to 2 doors before the diagnosis is being made. So हमको कभी भी suspicion जरा सा भी लगे, as you said very rightly, presumptive diagnosis. So if you increase the awareness among the patients, among the doctors also. So if we do that, then our number of patients are going to increase. That is the notification. Right, over.
Thank you.
Absolutely.
Thank you, Dr. Salil. Thank you, Dr. Manoj, and welcome, Dr. Sandeep, once again, one-to-one. It is always such a pleasure to, discuss with you and to conduct you. I learned so much on the sidelines. So great discussion has been started, Dr. Manoj, and, I can see a lot of interesting things coming. I must share with you, and I am being very, very candid in expressing it, that it happened between me and the team leads also, that the presumptive TB sputum, examination, it came as an aim statement as well in our PDSA. And it has come as an outcome measure. It has come as a process measure as well. And we have had huge amount of discussion where to actually fit it and use it. So much so that a lot of PDSAs are going on, Dr. Sandeep, on sputum examination and how we should increase the number and how we can do it better. So I'm sure all the DTOs are going to benefit from your talk. Prior to that, Sadaf, may I request you to share the screen so that, one by one, we can start having a look at what are the PDSAs we are going to present. And with this, and I will be inviting you only, Sadaf, to make the first presentation of the day. So Dr. Chauhan, Dr. B.M. Chauhan, he is DTO of Chota Udaipur, slide number 3. I welcome you, Dr. Chauhan, to make your PDSA presentation. And next will be Dr. Ravindra Tate, DTO Sangli. So I will keep the next DTO also informed, and Ankita will be presenting the sharing the screen. So Sadaf, may I request you to invite your DTO and share the screen also. And while this is going on, Dr. Sandeep, you will see that all the PDSAs that we will discuss today will be on increasing the notification, either public or private, because this is what this project is all about. We are focusing on boosting the TB notification that has suffered because of our preoccupation with COVID in the last 2 years. Yes, Dr. Chauhan.
Good evening, all respected sirs. Myself, Dr. B.M. Chauhan, working as a district TB officer since 1 year. Just before that, I was working as a officer in Chota Udeipur district, and then I was get promoted as a district TB officer. Our main aim problem statement is that there is low private notification in the Chota Udeipur district, and due to lack of engagement from the Ayush practitioners and chemists. So we made our aim statement that in Chota Udeipur district we will increase the private notification by engaging 10%. Already we are getting 70 to 80% notification from the private sector. For as per the target, we want to reach from 105% to 115% within from June and July, using engagement with Ayush practitioners and chemists. So that we have planned sensitization meetings with the private doctors and chemists, and there is a two blocks where there is a lack of private practitioners and some Ayush doctors are more there. So specialized or multi-specialties hospitals are quite only limited to one block, only Bodeli. In Bodeli Taluka, only some specialist and multi-specialist hospitals are there. So we have to more engage our Ayush practitioners, homeopaths and Ayush doctors for more referrals and for sensitization, so that we can get notification from them. And chemist association meeting also we need to focus. So I have conducted sensitization of the private doctors in Naswadi Taluka, and one meeting, a small meeting conducted with our chemist association. And as per that, in my team, STS and my DPC and our STLS included in my team, and the process was started, sir. Then we will getting some notifications from the private sectors. From chemist association, we still now we not getting any information. We are trying to sensitize one another training session with the chemist associations. So these are our focus areas, and after 1 or 2 weeks, I think we will get the results, sir.
Great. Thank you so much. Yes, I can see some photographs also.
Yes, sir. We have also focused. We make the this training in which government doctors and private Ayush doctors jointly. I have oriented them about our NTP program and our services, NTP services which are provided by our government setup. All things are discussed with them, and after that 1 or 2 cases, 1 or 2 referrals from the private doctors I get. Before that also I personally visit the private doctors, and our jointly team efforts are continuous to increase our private notifications, sir.
Thank you.
Excellent.
Thank you, Dr.
Excellent.
Chauhan.
Dr. Chauhan, this is superb work. And then especially what we see is that you have noticed that, yes, you may be at 100%, but there's still room to improve on that at 105% of the target, and you are clearly finding more cases. Now what you will see over time is that you will be able to extract all of the cases, and your notification will then plateau. So that's excellent work. It will boost, and then it will plateau. And after it plateaus, then it will come down over months. That's when we are looking for that 10 to 15% decline in TB notification and incidence over time. Excellent.
Thank you, Dr. Chauhan. Thank you so much. And absolutely, Dr. Manoj, you pointed out exactly what I was going to talk about, that, our DTOs are selecting their own targets. They are not confining themselves to the target which, they're getting from STO and CTD. This is where the PDSA is playing its role. They are going beyond because they have realized that there is a scope of getting more cases from there. That is one. Number two, Dr. Chauhan, lot of DTOs have made some WhatsApp group with their chemists. Okay, that's one another way of reminding them that they have a responsibility towards us. I will request Sadaf and Tariq Tarshik to make sure that they give you information on that. And Ankita and Sadaf, that we had shared one letter from a DTO which was informing all the chemists and drug sellers about the H1 notification. It's a polite, nice reminder to them. Okay, we have the official language with us. It is in Hindi. We can share it with the DTO Chota Udaipur. He can translate it so that at least he has a workable model, and we'll help each other like that. So these are some processes.
Sir, before we have started this notification program, we have one letter with our DDO sir, and from that letter was targeted to our private practitioners. And I have personally circulated some leading practitioners, and I have met them and give that letter and give emphasis on the notification. So it will also increase our notification, sir.
Great.
Excellent.
Thank you, sir.
Excellent. I think Dr. Sandeep Mishra had a comment. Yeah.
Yes.
First of all, congratulations, Dr. Chauhan. You are doing very good work by involving these Irish practitioners. During your presentation, I can just suggest you 2-3 points over here. One is very well said by Raman sir, like we have to see about Schedule HL implementation. Secondly, you were talking about chemist association. So I would just highlight one thing, like if suppose you are not able to catch hold of chemist association president and secretary, you can talk to your drug inspector of your district. There must be some drug inspector in your district, and these drug inspectors are very well connected with president and secretaries of the district level chemist association. So you can meet them, you can organize some event with them, and you can even request them to get implemented Schedule HL reporting by all chemists. And just last request to you, Dr. Chauhan, during my presentation, I will be speaking something more in details about how and how we can go with Schedule HL and why it is important for us. So I think you are doing good work, and I think those slides will be very much helpful to you in planning your future activities.
Great. Thank you so much, Dr. Mishra. And over to you, Commodore Raman and our QIC teams.
Thank you. Thank you. And very nice, Sadaf. We must play the next screen in time so that, the audience can see that who's going to be the next speaker. It is time for me to invite Dr. Ravindra Tate. He is DTO of Sangli, and he will make his PDSA presentation. And Ankita, may I request you to start sharing your screen? Dr. Tate, how are you? Dr. Ravindra, मेरी आवाज आ रही है?
I think he is on mute.
Yes, sir.
Yeah.
Sir, Raman sir, Dr. Raman sir, can you hear me?
Yes, we can hear you very well.
Dr. Manoj sir, especially very good evening, everybody. And we are proud that like for Sangli being a small part in Maharashtra, giving us an opportunity for the presentation. Sir, Raman sir, you know that it started with Dhule. First presentation was Dhule. And whatever the sessions were there, we were very proud and very informative sessions. For every session was means if you ask me what you have got from all the sessions, we became smart, sir. Like specific, measurable, achievable, realistic, and time bound. So this is the thing what smart DTOs you made for overall, we can say for India also. This was the first thing what was there in my mind. Sir, myself, I am Dr. Ravindra Tate. Dr. Nikita madam told me that we have to talk little less, but whatever the sessions were conducted were very beautiful sessions, sir, because every time, every new things were there. So we are proud. We can tell Dr. Arora sir is there, Dr. Manoj sir is there. Even we have listened about for Dr. Mohan sir also. And now Dr. Sandeep sir is also with us. Sir, myself, I am Dr. Ravindra Tate. I am a DTO for Sangli. All the presentations and guidance was done by Dr. Nikita ma'am and Shwecha ma'am. Sir, my problem is like referrals from Asha and medical officers were less. So we started working on them. So change for my district is Sangli district. Trying to change is increase in TB notification. What is the change is 2% change we can say, sir. And the change will be for within 2 months. In this 2 months, we will be sensitizing for the ASHAs, MOs, CHOs, lab technicians and private practitioners. Sir, my aim statement is Sangli district will be increasing for the TB notification by 2% within 2 months after the span. Sensitization of ASHAs, CHOs, lab technicians and private sectors will be done, sir. My team members are myself, I am Dr. Tate. We have a DPC, we have STS, STLS, TBHVs and PPM coordinators, sir. Sir, for pressure process measures and outcome measures, my process measures are number of ASHA sensitization, number of medical officers to be sensitized, number of lab technicians sensitized and number of PP sensitized. Outcome measures are total number of TB patients to be notified, sir. I have informed my team members also. Sir, if you see the sensitization part for my team or my district, we can say for ASHAs, I have 200 ASHAs in my district, in which 150 have been sensitized. Last 50 will be sensitized in in the second week of July. That can be done, and the photographs will be communicated to to you also, sir. Second one is we have a target MOs of 20 MOs. 12 MOs have been trained because we can't remove. Now 8 MOs are left. In the second week of July, all the MOs will be sensitized for these programs. Lab technician, we have 15 lab technicians. One was on leave, so it was not possible to train, but in the second week of July, we will train them. Sir, for TB, one of the important part is private sector. So we have near about 250 private.
I think we are losing him in between. Ankita, can you please complete the PDSA?
So they have 250 private practitioners and they have sensitized 38 up till now. So there they are going to work ahead. And there in the baseline period, their achievement was 140. Then in the training period, it was 186. So their target is 2% of 186, which is 190, which they will be working on in the coming period.
Okay, good. So you increase the target not from the baseline, but from the training period.
Yes, sir.
Okay, good. So you've given them a difficult challenge because 186 to already aa gaye 140 se.
Yes, sir.
Good. I think the DTO wanted to show something from his own side also, some personal slides I think he had made. We will give him opportunity next time.
Yes, sir. Definitely.
Yeah. So very nice. Sadaf, we'll be now calling Dr. Behra. Srishti, you please start sharing the slide, and after Dr. Behra will be DTO Dr. Rihana from Baramulla district.
Good afternoon.
Good afternoon, Dr.
Sir. So I am Dr. Santosh Kumar Behra from Jagatsinghpur, Odisha. Is it audible, sir?
Absolutely.
Yes, very much so, sir.
Very nice.
Jai Jagannath, sir, and Puri. So I am developed some new technology and new slide for to present. So basically, I am working here as a DTO so many years. I am good experience about notification. Real notification is going on in the periphery. So I have made new slide for it. So just 2 minutes, I will give me chance to explain detail about the monthly. This is monthly TB notification versus annual expenditure. So everywhere, every state annually, we have given the training. ANM, ASA, supervisor, pharmacist, MPHW male, female, even in private IMA members, staff nurse. Every time we are giving the boosting notification, increase the notification and feedback to this increasing notification rate. So we have spent, this is the annual 9, we have spent a lot of money for it, 4 lakhs, 21 lakhs, 22 lakhs. Everywhere we are not giving any lacunae to increase the notification rate at the involvement our paramedic staffs and medical staffs to increase notification of our district. So still now the cases increases 1 month, they again fall to the baseline. Increases 1 month, then it goes to again. It not maintain, still upgrade level to increase all the cases. Second phase, I have focused it. We have trained all ASAs. ASAs, through ASA, we are collecting the sample. Here, what happened exactly in the district headquarters, it is slide for district headquarters hospital. District headquarters OPD referral only 103. We have get positive 17. ASA, we paid incentive, lot of money incentive to ASA. They collected 327 sample in quarter January to June. We are 0 positive. Even laboratory practitioners, private practitioners also effective way, they have conducted 2 positive cases. So self patient already, so much they have come to the office, they are also 0. And this is the others, tobacco control program, HIV control program, they also report the claim, they are 0. So major notification rate will get the case at the district headquarters level or private practice level. If it is a district headquarters level, doctors will refer the cases exactly, and it is more than 2% referral, we will get the right cases and exact cases for our tuberculosis program. So second slide, just a minute, madam, please previous one. Second slide, I focus it. This is the total case detection rate. In our year 2021, we detected 357 cases, sir. Only microbiology confirmed 228, and clinically confirmed only 34. District level, there is no X-ray machine, although available, there is no radiologist, there is pulmonologist, and pathologist not available for extrapulmonary cases. Very lack defect in clinical confirmed cases and extrapulmonary cases. Although it is better one, but clinical is very low for detection level at the district level. We are not able to get other district clinically confirmed cases at the tuberculosis. So only we are getting only microscopically confirmed cases of tuberculosis. Around 200 cases were hidden cases every year, pulmonary clinical cases in the district. Second slide, this is next one, madam. So in this context, I have also focused when our counselor discussed, madam, we are conducting all IC activity, business activity, sensitization, training system in our district from 2006 to till date. Every year we are conducting, spending a lot of use money. Still now our case detection is very low, very low. So referral is very low from the district headquarters hospital, just 0.4% or 0.1% referral. So what to do? How will increase the boosting notification in tuberculosis? So accordingly, we have made the plan, number of sensitized monthly meeting, where monthly meeting we have sensitized, number of ICT we conducted, number of visit to follow-up cases by the STS and STLS visited, total number of public patient notified. Then our team DTO, DPCR. So exactly what happened, then DTO, DPC, PPM coordinator, STS, and PMDT. These are our team members. They cooperated to develop this type of program. Then, so here exactly what happened. MO was sensitized 15 every month, and number of visits done. Okay, number of visits done to track the follow-up. Suspected patient, phone call visit 150 we have collected. So number of IX also it is very effective way connecting to the visual meeting, through our TB champion and STS, STLS. Also they are conducting the regular meeting at the village, at the different community, political level, school, colleges, they are conducting meeting. So then, madam, so case detection rate, total number 15, 25, so it improve nahi ho raha hai. This is not never be increased so much. We expect July 59, but it never increases. Again, 12 come down to 9 or 12. So we will try karenge. So I am not supposed to sure about the case detection will be continue increase and it will maintain at in this level. Next. So this is the very good photograph. I have designed it and sent it the community meeting. We have conducted regularly. We are conducting a lot of IC activity, community meeting at the different peri-district level, different school level, community level, village level, different Muslim community level. Everywhere we have community meeting. Next. PDS cycle, same. We have conducted this the program. What is the aim and process measure? We are accordingly we follow and maintain this type another 1 to 2 months. Again, I will follow this process measure. Then next slide, madam. Next slide, process measure. Quarterly, monthly data. this is the monthly data. Same thing I have projected. The detection is very few, 30, baseline 20 around. We are maintaining the target mean around 120. The increases, add-on decreases to full to baseline level. It not maintained at the high level. And also this graph also showing the parallel at the baseline level. And the IMA member also, IMA private practice also they are involved. Our PPM regularly contact with them and regular phone call with them. So a little bit increases. Private practice also they are sending the cases. So private practice cases also increases. Okay, next. Quarterly. In quarterly data, this is 100%. Our target is 400. 100, but our this is target line, 100 line. Our state government has provided us 400 cases per year. So quarterly we can get at least 100 cases, but it's not like maintained properly. 1 month increases, then also decreases, many decreases point. Only increases once or 2 times it increases, but our target not achievable. Always our not target achievable at the cost of lot of money expense and lot of training, lot of ICE activity. We are not maintained at the constant level. We are always decreasing at low level. Any huge amount of money we're spending, lot of manpower we're spending, but always going in very low down. Also, but not maintain the okay. Next. This is my presentation. I need any suggestion and opinion from your panel to increase our accreditation notification in our small district geography.
Great. So Dr. Santosh, excellent work, and several things. One, even without an X-ray machine, you're able to accomplish so much. I think that's a huge credit to you and your team. That's the first thing. Second, you have very nicely done is you've looked at your process measures and then the outcome. And yes, always one may not see a direct increase in outcome measures, but you are clearly increasing your process measures, those things which are the sensitizations and there. Also, I will lead into our conversation with presumptive examinations. So what you may have seen is how did your presumptive examination numbers, did they go up, were they steady, or go down in over the past 4 weeks?
Presumptive never increases. Only at district headquarters hospital, we repeatedly we are requesting, our ADM also requesting them. Presumptive just 0.5, 0.6 हो जाता है, कहते 1 to 2% नहीं आता है. It is not increasing that much visible. Okay. It is only 0.4, 0.6, 0.6. वही में range में it is flowing. But it is never visible figure we cannot appreciate.
Okay. So a few things is when you have maxed out. Yeah. So when you have maxed out on your number of cases that you will find, which is your notification, when that is maxed out, then after that you will see a subsequent decline over time. So the goal right now is continue in all the sensitizations, increase the notification to the peak, and then look for the subsequent decline over the next several months. Great.
Thank you, sir.
Good job. And so good to see that aapne jo detailed graphics बनाई है. You have really taken this project to a new level, which is really exciting, that you have not just taken ownership, but you have taken ownership and then leadership to then demonstrate to our 200, 300 plus DTOs across the country, जो देख रहे हैं कि अपन कितना और कुछ कर सकते हैं. बहुत बहुत आभारी हूँ आपके ये सब काम से. You are truly a leader. Thank you so much.
Thank you, Dr. Jain. Thank you, Dr. Behra. And even I would like to just reiterate the same point, Dr. Jain. You know, DDG TB, Dr. Joshi had asked us that, you know, he wants to see that quality in his DTOs to make the presentation, to use the data, to use the graphs. And when, you know, Dr. Behra showed us all this, we only welcomed it, and we welcome it to all the DTOs. You know, we welcome all your new thought process, because we are stimulating and triggering these new thoughts in you, and we want it to be expressed. So it was so good to see your expression in way of data and graph, and we'll keep this presentation for some time use when we have to make a point that how DTOs are making the presentation. So now we will call Dr. Rehana, DTO Baramulla, Kashmir. Then we will take a break and we will have Dr. Manoj and Dr. Sandeep have a discussion, and then we will move ahead with the PDSA presentations again. So Dr. Rehana, बहुत स्वागत है तहे दिल से आपका.
Thank you. Thanks, sir. Good afternoon to everyone. I am Dr. Rehana. I am DTO Baramulla Bandipora. That's in the northern side of the Kashmir. We have a population of 17 lakhs in our district. I am looking after two districts, District Baramulla and District Bandipora. Our PDSA is like this. We want to boost public notification by 5%. Aim statement is to increase the public notification by 5%. We did intervention from 8th of June. We did sensitization of all the OSHAs, especially our topography is like this. We have a plain area and how to reach area, hilly area. So it's very difficult to go how to reach a hilly area. We have you might have heard Grace area, that is very steep hilly area. We had during this month in the month of June, we screened whole population. There was 37,000 population and they are scattered. They live very far away from one another, 5-10 houses at a place. Then we have to go upside. Nobody till date has been visited. No health facility has visited till date, but we visited and we screened it. We were having 12 team members from NTEP side. They screened it whole and they did 1300 sputum examination there. We were having our own STLs and LT. They did the whole sputum examination there. And beyond this, we sensitized medical officers of the area and other areas also. And we trained all the MLHPs in our district and in the Bandipora district, even in Baramulla districts. And we trained these private practitioners, especially chemists, private lab technicians, and private doctors. And we had planned to do intensify active case finding, and we did it in the last month. The presumption has increased 4 times from the previous one, but we are towards the NTB because our notification is coming very less, because last year we had achieved bronze medal. This year we are intending to apply for TB free, because now the notification is tremendously decreasing. So the process map was like this. The sputum examination from the ASHAs has, referrals from the ASHAs has increased, from the OPDs has increased, from the private practitioners and chemists and from the private lab technicians has increased, and due to intensify active case finding, the presumption has increased. I already told that we have increased the presumption 4 times. So after this, the clinical examination of the patients were done, and subsequently some were sent for sputum examination, and who needed X-ray, who did X-ray. After that, CBNet was done. If found positive, then we notified them in the NICSHE. And our run chart is like this. From 57, our baseline is 57. We have to achieve 63. We will try to achieve 63, but we are towards NTB. So it is maybe it may get difficult, but on our side we are increasing presumption. We are increasing 4 times, 5 times, but TB notification rate is less. And we have one challenge in our district. We have now at many DMCs, we don't have dedicated lab technicians. Facility we are giving, we then use our lab technicians. We have only 3 lab technicians in 2 districts, and we take the help of our STLs who helped us in this huge amount of presumption examination. From the other side, they are not so much dedicated. That is the problem in our case. Otherwise, we will be able to clean the whole Baramulla, Bandipora in 4 months. We will be TB free, or even after 4 months, if we will have plenty of lab technicians and dedicated lab technicians.
Beautiful, beautiful.
We have,
yeah, please go ahead. Go ahead.
Please go ahead. Please go ahead.
Sir, you may explain how to now help in a lab pot is poor in some DMs, not in all, because from the general health or NHM, they don't favor so much. It's only our own NTEP lab technicians who do sputum examination.
Excellent. Shall we see the monthly data for a second? Please, Dr. Ekta, if you can see, and then as well as the quarterly data. So what I want to make everyone aware is the following. We can look at what Dr. Rihanna has talked about, is they are maximizing all of their activities for the notification. And then they are seeing that they are each month that reaching that 50, 60 after the recovery, and it's maintained. And they are not seeing any more cases that are coming across, even after doing so much active case finding. What that tells me is that TB is on then plateaued and on the decline. So Dr. Rihanna, great work. Congratulations, Aapko bronze medal mein, and we are all cheering for you to reach that TB-free work. This is a great example for all of our other DTOs to see the trajectory of how TB gets eliminated, district by district, city by city, village by village. This is the pattern of transition that happens with TB. It's all a local disease. ये मैं आपको इतना emphasize नहीं कर सकता हूँ जितना कर रहा हूँ कि ये पूरा, it's a local problem. And you will see pockets of TB-free India happen in district by district. We want your districts to be the first in all of that to happen. And that is why every resource that we are providing. So thank you so much.
Thank you, Manoj. Thank you, Dr. Rihanna. Sadaf, you may stop presenting, please.
And then I will now take the conversation with Dr. Sandeep Mishra. Commodore Raman, your thoughts?
Yes, absolutely. My intention of breaking with Dr. Rihanna was this much only, because, we have always been trying to make a point that she's focusing on improving the presumptive examination 4 to 5 times, yet there is no increase in the notification. A clear indication that, the district is going on the right path, which you illustrated to. So that's why, we thought we'll take a break here. So this thought stays in the minds of the DTO. And over to you, Dr. Jay and Dr. Sandeep, to now take up this discussion of presumptive examination.
Great. So Dr. Sandeep, walk us through the thinking and in a conversational way of both the notification part as well as the presumptive examination and the value of presumptive examination in the thinking about notification.
Yeah. So first of all, good afternoon, everyone. This is Dr. Sandeep Mishra. I have been working in the field of TB for so long, and whatever I've learned, I'm just trying to put it over here for you. Like whenever we talk about notification, it's basically most of the time we just talk about public notification, but we have to take into account private notification as well. And what is public notification for us? When TB patient is notified by public health facility, that is maybe at an PSC, CSC, SCW, SDS, civil hospital, district hospital. So at any public health facility, the patient is reported in TB program, that is public notification. And for private notification, any person who is notified by any individual clinic or private practitioner, nursing home, any hospital, corporate hospital, NGO trust, health facility, or any lab, or any radio diagnostics, any X-ray center, or by chemist also, then they are covered under private notification. Next, please. So before going to actual how we can improve upon notification, I'll just try to show you the presumptive examination rate of Q1 2022, this year only, from January to March. And whatever the figures you are seeing in the right cells, these figures are this figure per lakh population. This is per lakh population. And I will just tell you one thing, like, right now India is standing somewhere around 1,000 per lakh population as examination rate for presumptives. And most of the states are in the range of 600 to 3,400. That is the range for presumptive examination rate. And when we talk about TB elimination, what is the process? What are the steps? So first step is to increase our presumptive examination rate, and constantly increasing presumptive examination rate, you will in initial phase you will get more and more number of notification. But over the period of time, if suppose you sustain that increased presumptive examination rate, your notified TB cases number will come down slowly, and then there will be one step, and after that it will be only downtrend only. And then
so Sandeep, I'm gonna pause for a moment and ask you a question.
Yeah.
So okay, I'm in, say, the district in Indore. And I want to make it TB free. Yeah. My question to you is, what should be my presumptive examination rate? I know that for India, it is about average about 1,000. I see that Andaman and Nicobar at 3,143. I see Bihar very low at 290.
Yeah.
What should be, if I'm a DTO, what should be my ideal presumptive examination rate per lakh population?
Like as I said, most of the states and districts were in the range of 600 to 700 till 2016 and 17. But when we started thinking about TB elimination, the first step was to increase TB notification. And for increasing TB notification, the basic thing is to increase TB presumptive examination rates. So like if suppose as you are talking about any specific district of Indore, or for that matter any district, like Indore is a very progressive district, and if I take an example of Indore, right now its examination rate should be in the range of 1,500. But overall, suppose you see MP is ranging between 600 to 800 in last 2-3 years. So firstly, as a state, as a district, you will have to see, like, like where are we standing for MP? Right now,
1,053.
1,053. So this has improved in last one year. But if suppose you just see the trends for TB elimination, if you really want to achieve TB elimination, if MP is showing 1,053, then Indore must be in the range of 1,600 to 1,800.
Sure. Sure. We can look at a lot of places, like you can look at Chhattisgarh, whereas Chandigarh is at 1,600.
So just coming to your answer, Dr. Manoj, firstly, we will have to increase presumptive examination rate as maximum as we can. And in my preceding slides, I will show you the ways, whatever I have learned over the period of last 17-18 years in TB program. I have just put down all the crux of that, like how we can improve upon TB presumptive rate, whether we talk about public health or we talk about private sector.
Right.
But there are certain challenges, and we have to, go beyond those challenges. And we should not be thinking about TB elimination for now, but we should be simply thinking about how we can increase TB notification in public sector. And for the district like Indore, we can think more about for private sector.
Got
because Indore is having a big chunk
Sure.
of private sector.
So
we will have
let's talk about for any DTOs. There are over 200 DTOs who are on the call with us.
Yeah.
My question for each and every one for the DTOs is the following. Are you looking at your presumptive examination rate, and is it below that 1,000, which is the national average? And how can you get it to place like Ladakh or Lakshadweep? These are close to elimination, and you can see how they can do it. So we know that if we can increase even a large state like Gujarat, the presumptive examination rate is 1,749. So look at your district, look at your presumptive examination rate, and then see how you can increase it. And that itself will work as you can use it as an outcome measure or a process measure in making your notification go up.
Just to add to what Dr. Manoj is saying, you just see the example of Himachal Pradesh. Himachal Pradesh was somewhere in the range of 600 to 800 5 years back. But now today you can see how it has improved up to 2000, in the range of 2,400 to 2,500 in the districts. And now I should say, like most of the districts of Himachal Pradesh as a state are on the verge of TB elimination, just because of only one single effort, that how and we have to learn all these things from districts and DTOs of Himachal Pradesh. What were the things, what were the ways? Because if suppose you compare Himachal Pradesh with other hilly states like Uttarakhand or northeastern states, you can see the improvement, how in those difficult terrains they are able to manage all that. So there is a lot to learn from DTOs of Himachal Pradesh.
Great. So this is really important. You can see that the transition can be made. Himachal is a great example. And the DTOs who are here from Himachal, great credit to you. And even the Chief Secretary from Himachal is well known to us and has joined us on other conversations. So wonderful. But Dr. Sandeep, let us now go into the depth of this.
Yeah.
We know, I agree with you that we need to increase our presumptive examination rate. You have convinced me, and you have convinced me that I have to go beyond 1,000, and I need to get to 2,000 per lakh and even 3,000 per lakh if I'm going to increase my notification and reach that plateau and then come down on there. But let's talk a little bit.
Yeah, ideally, if you ask me, I will request all the DTOs present over here that, we should think of minimum getting 2,500 first.
Got it.
It's
so
a big
you're
task.
You're putting a target 2,500 like Himachal.
But the approach cannot be like that, today I am standing at 600 and I'm just thinking about 2,500. It cannot happen in a day. So you will have to set some milestones for your monthly and quarterly as an indicator, and then you should see how you can improve upon. And during this slides only, I will show you very simple steps, very simple ways of how we can improve upon.
Absolutely. And as we're going into this, I want to impress upon all our DTOs the following. मैं अभी एक हफ्ते पहले इंडिया में था. I was in India, in Delhi for 4 days, meetings at the ministry level, meeting with WHO, meeting with USAID, CDC. And in those conversations, almost everyone mentioned the need for increasing presumptive examination. And that is why I have brought it as a real strong priority.
Exactly.
Because I was talking about notification, and what they were saying, look at the root cause. Look at what will drive your notification higher. And it is the presumptive examination rate, and going from 1,000 to 2,500, as Dr. Sandeep is saying. Please.
So, suppose we see how the cases are found in public sector. So there are only 3 ways of case finding. One is passive case finding, one is active case finding, and the third one is intensified case finding. Next, please. Now, when we talk about passive case finding, so what happens here? If any person is suffering from any symptoms of TB or any disease, that person himself report to the health facility. And how we can, so that is passive case finding. And how we can measure this passive case finding is like we can set the target for each health facility for presumptive examination rate. Like now our DTOs do have district level presumptive examination rate as well as TU wise presumptive examination rate. Same way, smart DTOs, what they are doing, they are calculating for their individual PHIs, like what is the presumptive examination rate of the day and what should be the target I will be giving to the medical officer of that PHI for next quarter or next month. And this way, by setting up the target is not, you are not going to achieve anything. Then you will have to have monitoring from district level as well as state level for individual PHI. Right now, most of the states are doing monitoring only up to the district level, and district level monitoring is happening only up to the level of TU or TB unit. But I will suggest, please go one level below down and see whatever the targets you have set for PHI, whether they are able to achieve it or not. Please monitor those targets on monthly basis or fortnightly basis. And if suppose any medical officer or their staff do require some more inputs or more information or more resources, whatever is required, please try to provide that thing also.
So you're telling us we can even improve passive case finding to a new level.
Yeah.
And focusing on presumptive examination as a target for our individual healthcare facility.
Yeah. Excellent. And while doing that, see, if suppose we just give the targets, that is not going to suffice. We'll have to see the resources also. So I am specifically putting more stress on resources, like, if suppose are we in a position to increase more number of designated microscopy centers or microscopy centers, or if suppose we are not able to do that, then what are the means and ways by which I can connect those PHIs to DMCs by establishing some sputum collection centers in those centers where I don't have microscopy center or availability of lab technician or the microscope. So at least we can arrange, we can place some sputum collection centers over there so that they can be connected with the microscopy labs, and your presumptive examination rate can be increased more and more. Same way, ASHAs, ANMs and other field staff should be given some target for identifying presumptives. But I should add one more thing, like, health and wellness centers are coming up like anything in public health system. So we should see as a district TB officer how we can involve CHO of Health and Wellness Center in identifying presumptives as well as linking them for this testing and examination centers. So can you please come down to
absolutely. Yeah. So going back. So now we come to
last slide, previous one. Yeah. So again, coming to this, again, we can think of one more measure which I have suggested over here, like LTBI implementation. So if suppose your district is implementing latent TB infection diagnosis and treatment facilities, then see, there is a screening system for infection, but within that process, even we are able to get some more new cases. So again, try to go to maximum population, maximum contacts of active TB cases for diagnosis of infection, because these infected cases are only going to become the future TB cases for us.
Right. So LTBI can be a new measure.
Whenever we talk about elimination, we'll have to think about broader spectrum, like, and and this, see, we are talking about passive case finding where, if the person comes to know, yes, I am suffering or I may be suffering from this, then only he is going to report to the system. So to create that awareness, what measures we are taking, because many of the times now, whenever I am going into the field or I am seeing the field, DTOs are very much involved in everything. They are trying to do everything, but they are missing out the basic concept of ACSM. advocacy, communication, and social mobilization. So we'll have to see how we can educate our communities, how we can educate our people to make them understand what are the symptoms of TB, so that if suppose any of them or anyone in their vicinity is suffering from any such symptoms, at least they can self-report to the system and increase our passive case finding effort, increase our presumptive examination rate also.
Sure. So I'm going to summarize very quickly here. So what you're saying is, look, if you want to increase notification, you got to look at passive case finding. Targets should be set for facilities with the presumptive examination as one. Monitor the districts and the states, work with ASHA workers with their targets, look at LTBI, and also make sure to continue with the communication and all. That was passive. Passive is when people will come when they're having symptoms. But now the second thing you're telling us is we need to be looking at active case finding. Tell us quickly on this.
Yeah. So see, active case finding is a part of program since 2007, late 2017. But over the period of time, we people at Central TV Division, we people at state level, we were very, enthusiastic about active case finding. And right now also it is happening. But, I should accept this fact over here on this platform, because we are talking only to the district TV officers over here, that it is still not giving us the yield which we expected out of this important activity. And what are the mistakes generally we do in our enthusiasm? Like, we have been given a list of what are the sites, what are the pockets of population we should go to. But it may happen like, for any specific district TV officer, now I am giving you a very new perspective. Like, how many of our district TV officers are trying to plot active TB cases on a block map or a TB unit map? And if suppose we are able to do that, we will be able to highlight some hotspots in the districts where we are getting maximum number of cases. And if suppose we are identifying TB cases, so TB cases will be coming only from the area from where TB cases are coming. So we have to understand this fact. And if suppose we do understand, then our site selection will be more proper, more practical, more realistic, and then only we can think of. Because if we are going to any site just because it is written in there, like, you have to go to slum or orphanage or prison or whatever the place.
So but very important point of proper site selection.
Yeah,
we've got limited time. So Dr. Sandeep, I'm going to ask that you to just go through some of these, because we have other PDS to present as well.
And then secondly is proper team constitution. So you will have to understand, to whom you are sending, what is the ability of that team members, or what is the constitution, how many of, field workers or locals you have kept in that team. Then meticulous and vast trainings. Your training should be very, very clear. Your messages during your training should be very clear to them, like what is an objective for what you are doing over there. And most importantly is timing. Like suppose I am constituting a team going to some slum and I have kept my timings from 11 to 2 p.m. But after entering that site, I came to know,
no one is there.
Have gone since 8 a.m. in the morning for their work.
So I'll tell you a story, Dr. Sandeep. So every time I come to India and in Indore, and I go each visit, I have a rule: 2 hours in a day that I am there. I am either at a slum, or I am either at a village, or I'm either at a work site. And when people, my team from CETI says, sir, we'll join you, but can we do it at 11 o'clock in the, or 12 o'clock? And I tell them each time, you can do it, but no one will be there. क्योंकि वो भी काम पे चले जाएंगे. They're going to go to work. वो भी काम. So doing active case finding at 12 o'clock in the afternoon, 2 o'clock in the afternoon on a winter day does not make sense. No one will be there. You have to go there at the times that people will be there. And that is a lesson that we all must learn.
And just one suggestion for that, before going to that particular thing for an activity, we can send one representative 2 or 3 days before, just to have a local understanding of the timings and availability of maximum number of localites over there. Then again, we have to select the site of your activity, whether you are going to do this activity at their residences or their workplaces. You can decide upon that. As a district TB officer, you are the best judge of the situation. And most importantly, the activity itself, people should be aware all the time during that duration of 10 days or 15 days or a month, whatever you have kept for the activity, like what should be the qualitative measures. And then if suppose someone is left out, then who is following up with those missed out cases? Then very importantly, throughout the activity, you will have to monitor at micro level for every site. Like if suppose as a district TB officer, I have selected 10 sites in a district or 10 sites in a city. So it's not like, in evening I will be compiling reports. At the end of week, I will see all the cases. No. On daily basis, you have to make frequent calls, frequent visits, or just like what Dr. Manoj says, you have to visit yourself over there during the activity. Then only you will be able to see what people are doing, or they are just, going for the sake of going over there. It should
Got it. So great. Dr. Sandeep, we've got lots to go through. So I'm going to ask you to rush through the ideas. You talked about intensified case finding. Active case finding, passive case finding, then intensified. Tell us very quickly what you mean by this.
What is intensified case finding? When patient is not coming for TB disease, he is coming from some other illness like HIV or diabetes, and there we are doing that TB testing apparently and trying to get the numbers. So I'll just talk about this. We can have effective collaborations with HIV program, NCD for diabetes. Then there should be cross reporting, that too by direction. Both of the departments should exchange their reports of how many cases of diabetes they are seeing, how many cases of TB you are seeing, how many TB cases you are subjecting for diabetic testing, and how many diabetic patients being tested for TB. So you have to see the monitoring of each and every case. Like it's not only notification or it's not only the diagnosis, but what happens after that, that also need to monitor. Then timely provision of counseling and services, specifically at HIV facilities, you have to see what kind of services are there. And joint monitoring activities include meeting of both programs in one place, so that, if suppose they are facing any problems in meeting or whatever way, they can, correct the things.
May I do this, Dr. Sandeep? We have about 6-7 more PDSAs to do. There's a lot of conversation. Shall we save the slides and the content?
Just 5 minutes more. Just 5 minutes.
Okay, absolutely. And then we'll invite you again on this conversation.
These 2-3 slides are more important from a private sector perspective. Like, what are the measures, how you can improve upon private sector notification. So I will suggest all the district TB officers to fix the duty of your senior treatment supervisor at TU level to bring up a line listing of all the facilities in his or her TU. The second is, Central TB Division has shared one NHRR data list with all of you. So you can utilize that NHRR data. It is showing you how many labs, how many hospitals, how many clinics, how many PPs are practicing in your district, in which area, in which block, in which TB unit. So you'll have to see whether your NICSHA registration is happening for all or not. If not, then ensure that proper NICSHA registration of all the private practitioners, clinics, hospital, corporates, nursing homes, laboratories, radiology units, chemists is happening. Then review on monthly basis, how, like you have registered 200, but only 20 are active. So you will have to monitor whether these active referrals are coming or not, active notifiers are there or not. And if it is not, then as a district TB officer, you will have to take the measures to improve the number of active notifiers. Then most important thing is there any mechanism as a district TB officer you have said, or you have sit with your drug inspector in the district to monitor TB drug cell, anti-TB drug cell in your district, because that will give you an understanding of actual private TB load in private sector. And most important thing is effective implementation of Schedule H1. Now, why schedule H1? Next slide, please. Why schedule H1? If you are implementing effective schedule H1, then these are the things which you will get from the schedule H1 register. That exact information on anti-TB drug cell, from where you can estimate the exact number of TB patient. Then you will get name-wise details of each and every privately notified TB patient, then age and gender-wise breakup of those TB patients, and then you will be able to follow their system and practices, how much duration they are adhering to the treatment, or how many of them are leaving the treatment. Then information on patient-wise unfavorable outcomes like loss to follow-up or death or relapse, or even change in regimen. All this information you will get from H1 schedule TB notification. This H1 notification. Please, last slide, last point in last slide.
Yeah, schedule H1 implementation.
Previous slide. No, previous slide. Yeah, and information on total gap in private notification. Like if suppose you are able to get information of 200 patients through schedule H1, but your private notification is only 150. So as a DTO, you will come to know that there is a gap of 50 notification, which has already happened. Diagnosis has happened, but I have not got the information. Next slide, please. And then information of private practitioners who are not notifying, because you will come to know about those patients being prescribed medicines by doctors. You will get the prescriptions also, but no notification. And again, there may be some doctors like, if suppose there is one doctor, Dr. Mishra, who has notified 5 cases, but through schedule H1 you come to know that he has actually diagnosed 20 TB cases. So as a district TB officer, very humbly you can go and say like, this is a gap. Then patient movement from one private practitioner to another. This is a very common practice, but you will be able to see that also. Then patient practices of medicine purchase, like, any private practitioner has prescribed medicines for 6 months, but your patient is purchasing medicines for 4 days, 5 days, 10 days, 15 days, or 1 month in one go, you will come to know that. Then you will be having some answer to those missing million, which we are talking since 2015 till now. And you will be able to understand the precision practices of private sector doctors in your district, whether they are following STCI guidelines or not, and what is the gap in knowledge of diagnosing and treating TB. Then you will be able to have geo mapping of TB patients also. And the last point would be like you will be able to see knowledge, attitude, behavior, and practices and approaches of TB patients, how they behave.
Excellent.
How they do.
So this is a really, really important point I want to impress.
This section. If anyone do have any queries, I'll be happy to answer.
So really important point for all of our DTOs. And I see that Dr. Dave from Gujarat has said he hasn't been using H1. We will come to this conversation in more detail. And I would be very interested because I have been looking at the H1 schedule data as well. So Commodore Raman, over to you. And let's listen to several more PDSAs. And we will be having more conversation with Dr. Sandeep as well, because this is really, really interesting stuff.
Thank you, Dr. Sandeep. Thank you, Dr. Jain. Thank you so much. You have given us a complete overview, all possible process measures were there on your screen from presumptive notification. Thank you so much. And yes, H1 notification, Dr. Jain, our focus has been there at all times. In fact, beginning of the presentation also, if you realize that, we spoke about that one DTO has sent a letter and we said, let's give it a copy to all the DTOs across the country so that they can translate it and use it immediately. So with this, I call upon Dr. Radhakrishnan, DTO Kathua, Jammu, and to make his presentation. And thereafter, the sequence will be Dr. DTO Alipur, DTO Uttarkashi, DTO Thiruvallur, Srishti start sharing, DTO Shahadra, DTO Mau, and then DTO Lohit. So yes, Dr. Radhakrishnan, can you hear me?
Very good evening, Manoj sir, Raman sir, and all the participants. I am Dr. Radhakrishnan, DTO District Kathua, UT of Jammu and Kashmir. सर पहले तो मनोज जी ने हमें जो पॉइंट बताया प्रिजम्पटिव एग्जामिनेशन का ये सर हमारे प्रोग्राम को चलाने के लिए बैकबोन है। ये मैंने प्रैक्टिकली अब जब मैं PDSA बताऊंगा तो इसमें ये प्रूव हो जाएगा। सेकेंडली डॉक्टर संदीप ने सर जो बातें कही हैं सभी प्रैक्टिकल बातें सर, अगर हम इनको फॉलो करेंगे तो 2025 तक हम TB को खत्म कर पाएंगे। तो सर मेरे TU में 7.5 लाख पॉपुलेशन है। फर्स्ट क्वार्टर में सर नोटिफिकेशन थी 73% ओनली। तो उसके बाद सर जो हमें नेशनल टारगेट्स मिले हैं CTD से 190 केसेस पर लाख पर ईयर के हिसाब से, और स्प्यूटम एग्जामिनेशन निकला सर 1500 पर लाख पर ईयर। तो अप्रैल महीने में सर हमने ये अपने टारगेट्स ब्लॉक वाइज डिवाइड किए। पहले एनुअल टारगेट किए डिस्ट्रिक्ट के, उनको एज पर पॉपुलेशन पूरे ब्लॉक में डिवाइड किए सर। तो उसके बाद ये ब्लॉक से जोनल मेडिकल अफसर हेल्थ एंड बैलेंस सेंटर तक ग्रास रूट लेवल तक हमने सेंसिटाइजेशन कर भी रहे हैं और की भी है। तो उसका सर रिजल्ट ये हुआ कि हमारी नोटिफिकेशन 73% से सेकंड क्वार्टर के एंड तक 98% हो गई। और प्रीजेम्पटिव एग्जामिनेशन सर फर्स्ट क्वार्टर में था उससे 5 टाइम्स। फर्स्ट क्वार्टर में सर ये 393 के प्रीजेम्पटिव पर मंथ हुए थे, हमारे काम थे ये, लेकिन इसको हमने बढ़ाया तो ये 5 टाइम्स 1428 भी जून में हुए सर। तो मेन ये जो हमने प्रीजेम्पटिव एग्जामिनेशन बढ़ाया है उससे हमारी ये नोटिफिकेशन हाई हुई है। तो ये सर ये मेन हमारी प्रॉब्लम थी नोटिफिकेशन को हाई करना। तो उसके प्रोसेस में ये सर ये सेंसिटाइजेशन ऑफ MLHPs, आंगनबाड़ी वर्कर्स, आशा वर्कर्स, तो सेकेंडली IEC एक्टिविटीज। तो आउटकम सर इसका काफी अच्छा रहा कि हमारी नोटिफिकेशन मोर देन 20% इंक्रीज हो गई। तो अभी भी सर हम पीक लेवल पे 100% नोटिफिकेशन नहीं हो रही हमारी, लेकिन हम ये प्रीजेम्पटिव इंक्रीज कर रहे हैं और सब सेंटर लेवल तक हम डिस्ट्रिक्ट टारगेट्स दिए हुए हैं उनको मॉनिटर कर रहे हैं, और होपफुली हम विद इन 2 और 3 मंथ्स हम 100% नोटिफिकेशन लेके आएंगे सर। नेक्स्ट सेल में जाइए सर।
थैंक यू डॉक्टर राधाकृष्णन, थैंक यू सो मच। इनका प्लान 10% था ना यार, अभी कितने पे है ये?
सर मैंने क्वार्टर का बताया ये, अदरवाइज
yes sir, 10% from the baseline data, and we have baseline data of March and April. So this was 139, and we are planning to increase this 139 ka 10% in our intervention data. So
Excellent.
this is what the plan is.
Great.
Dr. Radhakrishnan, Krishnan, this is great work, and aapne key measures, number of samples collected by field workers. You have taken that very presumptive examination as a process measure. वो बहुत अच्छा काम है, और आपने देखा जैसे Dr. Sandeep ने बताया the impact that makes. So thank you so much and great work.
Thanks sir. Thanks a lot.
Sadaf, if you can share the screen, and thereafter immediately we will have DTO Alipur, Dr. Himanshu. बहुत-बहुत स्वागत है डॉक्टर हिमांशु आपका। आई एम सॉरी, थोड़ा सा मैं हरी अप कर रहा हूँ जिससे कि सबको मौका मिल जाए, सबके PDSAs हो जाएं और हम समय से खत्म भी कर लें। जीत उसमें है। सो यस डॉक्टर हिमांशु, प्लीज गो अहेड।
आवाज नहीं आ रही डॉक्टर हिमांशु की।
इनसे बातचीत तो हुई थी कंपनी शुरू पहले।
Yeah.
Go ahead, sir.
Namaskar and good afternoon, sir.
Yes, please.
My name is Dr. Himanshu Chaudhary. I'll just hurry through my PDSA. This time is short. I'm the DTO from Alipur Urban District in West Bengal with approximately 3.5 lakh population. When we reported around 2,200 TB cases last year. And the title of our PDSA cycle is Improving Private Notification in the District. In our journey to be TB free, our problem was low private notification. We ascertained that the reason behind this lies in the fact that there is no PPSA in our district from January 2022. PPSA that was engaged before has contract has ended, and there is no new PSA right now in my district. So we developed a team to address the issue, and the team members are myself, the DTO, and 2 STS are there, and 3 of the TBHBs I have chosen in the team. We then put together a process map. This was the process map here. And found out some points where I could intervene there, and there that patients were being diagnosed by the private physicians, but they were not being notified by them because of the lack of PDSA, and the data was not being shared to us. That is why we decided to intervene in that area. And also the Ayush practitioners practicing in those areas, there are 2 reputed homeopaths who are practicing in that area. They have not been contacted and sensitized earlier. We decided to sensitize them also. So just a minute, sir. So we decided to implement the change, and from the aim statement, our aim statement is to increase the private notification by 10% within 45 days, from 16 June to 31st July, 45 days. We then chose our outcome measures, which is the increase in private notification in Alipur. Then we chose our process measures, which is number of PPs contacted and sensitized, and then number of renowned homeopath doctors contacted, number of renowned homeopath doctors sensitized, and number of cases referred by the homeopaths. This we chose as the process measures. Then we started our intervention. Please show the run chart. And our baseline data showed that private notification of a total of 79 patients was done from 16 March to 30th April. And our intervention started on June 16th. And our preliminary findings are like this. We are seeing, we have done some sensitization of the private practitioners, number 16 in the first half of June. And we have contacted 1 homeopath. I am afraid I could not sensitize any of them, but I hope to complete the sensitization process within the next week. And still, my preliminary data is showing a steep increase in the number of private notification in the first half of June compared to the month of May, etc. And it is almost comparable to the baseline data. And some challenges we have faced and how we overcome them is that private patients were, as I said, the private patients were being diagnosed, but they are not notified with withdrawal of the PPS. We instructed all staffs to visit the PPs and polyclinics and collect data and submit to the district. In the district, we formed a dedicated team who will then convene once in a stipulated date weekly at the district and do the notification and all other data related works in the NICFI regarding the private patients. We are trying to sensitize more PPs and also the Ayush physicians, especially the reputed homeopath doctors in my district. In summary, please show the summary. In summary, we faced a problem of less private notification of Alipur, and we took a systematic change intervention. We measured and we are finding that the data has shown definite signs of improvement. We learned from this PDSA and I decided to adopt the cycle. There is no question of abandoning the cycle, and some of the I would like to keep this PDSA cycle open for some time more. Last of all, I would like to conclude that this simple PDSA cycle is a very interesting and highly effective tool. We are indebted to SETI for training us in this manner, and we express our gratitude to my esteemed course directors, Commodore Aurora, co-chairs Dr. Bhargava and Dr. Manoj, and all the faculties. I would also like to thank my UIC, Saraf and Annu from the core of my heart for their wholesale support given to us.
Thank you, Dr. Himanshi. Hold on, Sadaf, retain the slide. DTOs, we always talk about data, we talk of evidence, and some of you show the action photographs. And we also recommend that, when your ASHA workers and when your ground workers are telling you that we are working in the field, ask for a photograph, ask for evidence, ask for data. I'm not saying that we are doubting anybody's integrity, but at the same time, it does make sure that what is being claimed is happening. Right now, what is there in front of you is a NICFI data. Because the PDSA was going so well, I wanted to confirm, because what we saw in the open source NICFI data was not matching exactly with what was being claimed. So we asked the DTO and he showed us the dictionary data from his own source, and that is there in front of us. Once again, I'm trying to make a point. It is not doubting, but it is confirming. It is having that wonderful faith that we are doing the right thing and we are not going wrong. So please make sure that you also ask for the data, ask for evidence from your subordinates and team. Sadaf, please go ahead, showcase the next DTOs on the screen. I would be now inviting Dr. Kulveer Singh, DTO Uttarkashi. Once again, a very nice PDSA we'll get to see. DTO, Dr. Kulveer, can you hear me? Yes. Dr. Kulveer?
He may not be able to,
okay,
maybe unmute.
Move to the next one, Dr. DTO Trevalur, Dr. Lakshmi.
Hello, sir.
Yes. Good evening, sir.
Hello, Dr. Kulveer, sir.
Dr. Kulveer is here, sir.
Okay, झगड़ा हो गया अभी. Okay, Dr. Kulveer, please go ahead.
Go ahead, sir.
Sir, namaskar, sir.
Namaskar, Dr. Kulveer.
Please go ahead. Yeah. Dr. Kulveer, go ahead. Or we can have the...
Sir, namaskar. मैं डॉक्टर कुलवीर राणा, DTO उत्तरकाशी, सर, उत्तराखंड. सर, हमारी टोटल पॉपुलेशन है लगभग 4 लाख के लगभग है. और सर मेरी प्रॉब्लम है लो टीवी नोटिफिकेशन. हेलो.
Go ahead. Yes, we can hear you. हाँ, बोलिए. हाँ, बोलिए.
सर,
तो आपका एम स्टेटमेंट हमें नजर आ रहा है डॉक्टर कुलवीर कि आपने प्लान किया कि हमारा लो टीवी नोटिफिकेशन का ही प्रॉब्लम है. आपको मेरी आवाज आ रही है? हम आपको सुन सकते हैं.
सर
हाँ, आगे बढ़िए.
हाँ सर, मैं निकाल रहा हूँ, मैं अभी ड्राइव में था.
अच्छा, नो प्रॉब्लम. अंकिता, प्लीज गो अहेड, प्रेजेंट द PDSA प्लीज.
Yes, sir. So his aim statement is, in Uttarkashi, we will increase total TB sector notification by 5% within 2 months using sensitization of ASHAs, CHOs and chemists and number of referrals received from them. And his process measures are as follows. Number of ASHAs sensitized. So he planned to sensitize 600 ASHAs. Number of CHOs sensitized, which are 45. And number of chemists sensitized, again the target was 45.
I would like to see Ankita के 600 में से कितनी आशा इन्होंने अभी तक सेंसिटाइज करी हैं, because the best part is कि डाटा इनके पास है.
Yes, sir. Yeah. So here we can see in the run chart that till now 316 have been sensitized, and the rest are pending, which they will be doing ahead. We can also see on the graph. Then the number of CHOs, they have been able to sensitize all the 45, and number of chemists, 38 are sensitized, few are still pending. And here we can see their notification data. So in the baseline period, the total target that they achieved is 81. So in the training period, they were able to increase it by 19.75%. And now the target that we have set is 5% of 97, which is 102.
डॉक्टर कुलवीर, आप इसका मुझ पे इल्जाम लगा सकते हैं कि कल आपका टारगेट 89 तक था. जब मैंने आपका PDSA रिव्यू किया तो इसको 97 पे हम लेकर, और आपको शायद ये प्रेजेंटेशन से 2 घंटे पहले ही बताया गया होगा.
यस सर.
तो बहुत अच्छा चल रहा है आपका PDSA, बहुत अच्छी तरीके से आप फोकस कर पा रहे हैं, और इसलिए हमने आपका थोड़ा सा बेंचमार्क और ऊपर कर दिया. मुझे पूरी उम्मीद है, मैं आपको गुड विशेस देता हूं कि आप जरूर कर पाएंगे.
सर लेकिन हमारे यहाँ आजकल ही एक प्रॉब्लम आई सर. हमारे जो 2 फिजिशियन है सर, क्योंकि ज्यादा हमें वहां से भी काफी पेशेंट मिलते थे, तो दोनों का जो है सर सुपर स्पेशलाइजेशन के लिए हो गया है. हेलो,
ये
हो सकता है. हाँ नहीं, गुड न्यूज है, लेकिन सर हो सकता है ये कम हो सकता है.
नहीं होएगा, नहीं होएगा
सर. ओके,
नहीं होएगा. मेरे मुंह पे सरस्वती बैठी है, मैं जो कुछ बोल देता हूँ हमेशा वैसे ही रहता है.
ओके.
बिल्कुल बिल्कुल. थैंक यू डॉक्टर कुलवीर, थैंक यू सो मच. बहुत अच्छी आप मेहनत कर रहे हैं. डॉक्टर लक्ष्मी Thiruvalur, I think I had asked the counselor and the team lead to find out about the history of Thiruvalur, if you've done it or not. you must do it. Dr. Lakshmi?
Yeah, good evening, sir. And good evening to the respected BTN campaign for enlightening us with the PDSA, wonderful PDSA training, so that still we can percolate deep into our field level notification. And I am the DTO of Tiruvallur for the past 15 years. But in my notification of the low notification from especially the far off blocks of Ejepet, Amayarkuppam and Therampakkam. And I have to concentrate on those TUs wherein the notification from the root level of by the MLHPs and the women health volunteers recently posted from March month onwards, but they are kept idle. So we have to increase the notification by monitoring their work after the training from to the 3% increase in the notification, and the intervention started from the 6th June to the 28th July for 2 months with the intense monitoring of the patients referred by the MLHPs. And our main aim and our process measure is what are the male, I am very interested in the gender response also. So what is the male patients, number of male patients referred by the MLHPs and by the women health volunteers, and also by the NTEP staff. And the sputum samples, 2 sputum samples we needed. So one is the early morning and another one is the 2 hours after collection. So that also we have monitored, and the outcome of the measure is the work done, the work response from the field level as well as increase in the notification. So after this we are planned, and my team members were the DTC MO and the health educator and the public private mixed coordinator and the DRTP coordinator and the DEO. With them we have did the intervention with the, and our process measure were assessed in this table, showing that we are assessed from the May month baseline, taking as the May, and June is the intervention started for 2 months, and we can able to see the work done by the monitoring of the work done by the MLHPs and the women health volunteers, especially in screening the male, female and the transgender population, and that we can be able to we can show the increase in the referral of the sputum samples by the MLHPs in these months, not in the previous months. After the training, they are very much interested in referring the samples, and we have got the reported in the all the by the MLHPs is collected, and then it has gone recorded in the DMC, consent DMC lab register and entered in the NICSHI. Sorry sir, I didn't have the NICSHI report. I'll produce it later, but we send the daily Google spreadsheet so that every sputum referral has been recorded by which member, which unit of the our field level workers, and that we are able to get the samples of nearly that is notification has been increased from month to 9 notifications we have got till June 28th. So that intense monitoring, the outcome measure is definitely we had the increase in the notification by these 2 months by applying this PDSA. I am very thankful to you, so that our district can do the increase in notification by applying the PDSA in these low notification blocks, and with this we can move our district to the TB free. Thank you very much.
Excellent. Excellent, Dr. Lakshmi. You've been a DTO for 15 years, and you've seen many ideas come across. How would you compare this PDSA concept to some of the other training and ideas that you've seen?
PDSA, actually we are planning what are the intervention we need. First we have to plan, sir, and accordingly I saw the low notification in this far off blocks. These are the unreachable blocks. So I have decided the field level, because there want to only the public health facilities are there. There is no private health facilities are very minimal. So I am concentrating on those. We are planning accordingly to reach to get the work of the field level, the community. So we have planned accordingly, and we are giving the given the training to the available WHVs, the women and volunteers, and the MLHPs. And
Great.
yeah, so we are giving the intense training and monitoring, so teaching them, so that we can get, we are planning according to the, according to their, because they didn't know much thing, because our Tamil Nadu, we are giving the Makkale Thedi Maruthuvam, reaching the
Great.
patient's house is going on. So women health volunteers are posted there. So we are utilizing their services and planning
Excellent.
accordingly. Yeah.
Excellent, excellent. Thank you so much.
Yes.
Over to you, Commodore Ram.
Thank you, Dr. Lakshmi. Thank you so much. Very inspiring. So, Dr. Manoj, we have gone past by 5 minutes. We had taken only the time till 6 o'clock from the DTOs. There are still 3 more presentations left. And I can see Dr. Bindu Bahel is bilkul excited and ready to start presenting, because she's from our previous batch. So shall we stop now, respect the time, and take it forward to the next session?
Yeah, I think if we can do that, that would be great. We have another session coming, and then we can give due time to the DTOs and have a conversation more so in that detail. So if the DTOs wouldn't mind, we'll give you more time to present and more time for conversation.
डॉक्टर बिंदु मेहरा बहल, आप परिवार की तरह हैं. मैं आप पे अपना हक समझता हूं कि आपको रोक सकूं अगले हफ्ते तक के लिए.
Definitely, sir. Yeah, no problem, sir.
Which is great. You can see that there's so much conversation on each one of the PDSAs, and we're so delighted. Over 200 DTOs have been eager and wanting to share their PDSAs. So we want to give them due time and credit. So great.
So with this, Dr. Manoj, may I request you to give your closing remarks, because we have exceeded time, and I just kindly thank all the DTOs and can give us a smile. Please switch on your videos. Dr. Manoj.
Yes, absolutely. So as we close for today, we are making great progress, and we need to continue doing this. We have seen the many factors that determine notification. Aaj apan ne presumptive sputum examination ke baare mein in depth we've studied. We're seeing this incredible change from all the way from Kashmir to Tamil Nadu. You can see it. You can feel it. Let us continue all of this and show CTD with Dr. Joshi and others that we can increase that notification then to achieve TB-free districts, TB-free state, and TB-free India.
Thank you, Dr. Jain. Dr. Salil, any last closing remarks, thoughts from your side? And Dr. Sandeep, anything from your side, just about in 10-12 seconds? Otherwise, I would like to say that today we had the PDSAs from Gujarat, Maharashtra, Odisha, Jammu Kashmir, West Bengal, Uttarakhand, and Tamil Nadu. This is really wonderful integration. And with this, thank you, Dr. Jain. Thank you, Dr. Sandeep. Thank you so much. All DTOs, counselors, team leads. Thank you to CTD. Thank you to Emory Global Health Institute. Thank you, WHO. And thank you, IIPH Gandhinagar.
Great. We'll see you next week.